like that, and it's a very simplified thing. That so if you don't have that printed out, that's the very bottom page of the modules. And like I say, all the modules are open. Everything, Pearson's open. I shouldn't be, except for the only dynamic study module in the Pearson for the last chapters I gave you was the endocrine system, because it is so involved. Otherwise, I think you have a chapter test, and I don't know what else, but not very much. So you don't have very much left in Pearson. You only have one lab left, which will be the neuroanatomy / special senses lab, which would have been the fourth lab if we had a face-to-face. And I'm going to essentially give you the same lab that everybody else took. And it won't be hard at all. And it comes right out of the pictures in the book. So we're talking about spinal cords and nerves. Spinal cord function is a conduction system. Okay, we have the sensory afferent sensation thing going into the central nervous system. This is from the peripheral nervous system. Okay, and we have our reflexes. And then we have a system coming out, the efferent system, which is motor, okay? So we have a sensory system going into the spinal cord, which we call afferent system. And then we have a motor system coming out of the spinal cord. But remember, when we talk about motor, it includes not only the voluntary muscles, but includes the autonomic nervous system, which we will do next week, which is the final chapter of the nervous system. And then we have special senses, which is sort of in the nervous system, if you think about it. And then we have the endocrine system. That's literally all the chapters we got. We're going to look at this diagram up here. This is what this is actually, this is a schematic. This is actually the spinal cord dissected here. Okay. The spinal cord starts from the foramen magnum. Okay. It has a dorsal medial sulcus. Okay, which is just a indentation on the dorsal surface, and have a ventral medial sulcus there. It has some roots, it has dura, and it has arachnoid, and it has pia. And so if you look at the schematic and then come over here and look at the pictures, or look at the pictures in your textbook, it will make sense to you. Rarely, unless you're doing a dissection. And spinal cord is difficult to get to because you have to remove the lamina. You have to open up, if you're doing it from the back, you have to open up the lamina, okay? Or, and if you're doing it from the front, you don't see very much of the spinal cord. It's a very difficult dissection. And so spinal cord is not something, even if you go scrub on a procedure, that you see very much, because it is, it's not a very big area. And usually in your anatomy and physiology class, they have a prepared section where they can show it to you, because it takes a little effort to get the spinal cord out. Notice the spinal cord extends from the foramen magnum. If you remember the foramen magnum, in Latin, that meant big hole, down to L1 or L2. Okay, doesn't go down into the sacrum. Now, spinal nerves go down into that general area, but the spinal cord itself goes down to L1 or L2. That's why if you're going to do a spinal tap, then you usually do the tap, somewhere around L3, L4. Okay, that way you don't risk hitting the spinal cord with your needle, with your probe. And now, granted, the needle has a trocar in it as you're inserting it, but you wouldn't want to risk sticking the needle into the spinal cord. So this can catch you up here. It extends down to L1 or 2. It doesn't extend further than that. Gross anatomy and spinal cord. Here's another got you thing. We have 7 cervical vertebrae. We have 8 cervical nerves. We have 7 cervical vertebrae, 8 cervical nerves, 12 thoracic vertebrae, 12 thoracic nerves, 5 lumbar vertebrae, 5 lumbar nerves. Then down we get with the sacrum, we have 5 pairs of sacral nerves and 1 pair of coccygeal nerves. So this is a got you thing, okay? This is one of those things that people can test on or ask you about, that if you don't remember that you have 8 pairs of cervical nerves as opposed to 7 cervical vertebrae, then you can get hung up on this. There's a cervical enlargement here. The cervical enlargement gives rise to nerves to the upper limb, and those upper limb nerves are going to, some of them are going to congregate and form the brachial plexus, and we'll talk about that in a little while. And then we have a lumbar enlargement down here that's going to give rise to nerves in the lower limb. Okay. We have a medullary cone. This is the medullary cone, the conus medullaris. Conus medullaris. This is where the spinal cord tapers. So this is around L1, L2. We then have cauda equina, where the fibers of the spinal cord become loose and hair-like. These are not spinal nerves. These are the fibers of the spinal cord. Okay, the fibers of the spinal cord become loose and hair-like. Remember, the spinal nerves are going to go out in this direction. Okay. And then we have fili termini, which anchors the cord to the coccyx. So we have that enlargement place called the conus, okay, conus medullaris. We then have a cauda equina. And so if you've heard of a caudal block, somebody had a caudal block for delivery. They had a caudal block for delivery, and they went in L2, L3, 4. The caudal, in this caudal area, they would have been able to block the lower lumbar nerves, the sacral nerves, and the coccygeal nerve, which should take care of. There again, I'm not an OB/GYN doctor, but I do know that the caudal blocks were available for a delivery procedure. And then this is a structure that anchors the cord to the coccyx. And then we have dentate ligaments, which are filaments of pia mater that secure it to the dura mater. The pia mater extends down from the brain, because the spinal cord is essentially just an extension of the brain. So it has dura, it has pia, and it has arachnoid. And so we actually have ligaments that attach the spinal cord to the dura mater, okay? And these are called dentate ligaments. Nerves are mixed. So spinal nerves are mixed. What that means is that it has both sensory and motor fibers in it. Now, remember, when I say motor, and we're talking about the central nervous system, we're talking about voluntary muscles, and we're talking about autonomic functions. Autonomic functions may be speeding up and slowing down the heart, maybe dilating the capillary beds or constricting the capillary beds. But the spinal nerves themselves are mixed nerves, okay? That means they have both afferent are the sensory fibers, and efferent are the motor fibers in the spinal nerve, okay? Cross-sectional anatomy. Look at this in a little more detail. This is the spinal cord, okay? This is the white matter, okay? This is the white matter, and this is the gray matter. The gray matter has what's called horns, okay? And it has specific horns. We're looking at the front here. We're looking anterior coming out towards the screen, and posterior going back. The posterior most portion, okay, this horn right here is called the dorsal horn, okay? This is called the ventral horn, and this is called the lateral horn. So we have a dorsal horn, okay, which is posterior, a ventral horn, which is anterior, and a lateral horn. This is primarily gray matter. Remember, white matter is primarily myelinated fibers, okay? White matter is primarily myelinated fibers. Gray matter is cell bodies, and non-myelinated fibers, primarily. So this is where our cell bodies are, and this is where some of our tracts are. This is our myelinate, okay? The white part is the myelinated part. It has names too. It is called a funiculus, okay? This area between the two dorsal horns is called the dorsal funiculus. This area between the two ventral horns is called the ventral funiculus. And this area here, from lateral to the dorsal and ventral horns and lateral to the lateral horn, is the lateral funiculus. This is where the tracks are, the major tracks that go up and down the spinal cord. This is the dorsal root ganglion. This is the dorsal root ganglion. This is where the cell bodies of the sensory nerves are located. So for the afferent section that sends fibers into, afferent section that sends fibers into the spinal cord, we may have the receptor in the big toe, and it may go up to whatever the particular spinal nerve it's associated, probably a lumbar or sacral spine, probably a lumbar nerve. Okay, it would be a lumbar nerve through the lumbar plexus. And this would be where the cell body would be. Okay, so up until this point, we'd have a receptor and a dendrite, and then we have a cell body, and then we have an axon. Okay, and it could be one of those unipolars. Remember, a unipolar is literally one big process with a little small thing hanging off the middle of the process. And that was a unipolar neuron as opposed to a bipolar neuron where we had a dendrite, a cell body, and a definitive axon. So this is the dorsal root ganglion. This is dorsal root ganglion. This is the central canal. Okay, the central canal. Don't get tripped up on that, because there might be a question asking you what this is, and maybe call it something that's between the third and fourth ventricle. So make sure that you don't put this answer, even though you wouldn't know this answer, but you don't get tripped up on it, because that's not what the passageway is called between the third and fourth ventricle. This is the branches. This is the branches of the spinal nerve. They are going to coalesce and come together before they go out the intervertebral foramen. Okay, so this is still inside the spinal cord. So they're going to coalesce, but this is ventral median fissure. We have a dorsal median fissure. We talked about this anatomy. We have dorsal roots. We have a dorsal root here. This would be our the dorsal root ganglion. This is dorsal root. This is our ventral root. The ventral root is motor. The dorsal root is sensory. But this is inside the spinal column. Okay. Before it goes out the intervertebral foramen, it coalesces into a spinal nerve. So when it goes out here, this is now a spinal nerve, and this spinal nerve is, we mentioned that, is a mixed nerve. Okay, remember, it has both sensory and motor fibers in it. So I wanted to go over this because this is a really good picture here. So we have a gray commissure. So that is a small strip of gray matter between the right and left side. Okay. Dorsal posterior gray horns, entirely interneurons. Okay. Interneurons. Remember, we had a sensory neuron coming in. We had a sensory neuron coming in, and would connect to an interneuron that will usually go upwards into probably stopping in, if it's a higher order thing, it's going to stop in the thalamus, okay? It's going to stop in the thalamus before it goes up to the cerebrum. And we'll look at a couple of things when we look at a few pathways, okay? Dorsal posterior gray horn, entirely interneurons on the back side. Ventral anterior gray horn, so this is ventral anterior gray horn. That was dorsal posterior gray horn. Lateral gray horns are between those, and they're primarily in the thoracic and superior lumbar areas. Thoracic and superior lumbar areas, because in the other areas, the spinal nerves that come out of there go into plexes, the lumbar, the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. And we'll talk about those in just a little bit. White matter is arranged in columns, mostly myelinated. Okay, we have the dorsal posterior funiculus between the posterior horns, the ventral anterior funiculus between the anterior gray horns, and we have the lateral funiculus located lateral to the lateral gray horn. Spinal tracts. White matter is arranged in tracts. Each tract has axons for a similar destination, okay? In this particular diagram here, okay, ascending tracts are in blue, descending tracts are in red. And this doesn't mean you won't have some tracks here in the gray matter, but these are the primary tracks. Now you don't have to, obviously you don't have to memorize them. And even in the notes, you'll notice that there is 5 or less. Those are the ones you would have had to memorize if you were doing a face-to-face class, okay? But these are tracks, okay? There are no designations on the spinal cord. The spinal cord is either gray or white. What happens is you do stimulation. And find out what happens. If this was an ascending track that was related to a stretch receptor in a muscle, and you stimulated that would obviously go up into the central, it's in the central nervous system. It would go up to the cerebrum by way of the thalamus. A decision would be made, and if the muscle was overstretched, if that was a track that was looking at muscle being overstretched, that muscle, a similar thing, and you could do that stimulation and watch for a response. Obviously, this was done in animals. Watch for a response to see if that leg twitched or whatever, and got some kind of response. But these are tracks. I mentioned to you, and you may very well take a course. If you take a course in neuroanatomy, which is just essentially peripheral nerves towards the last part, but primary central nervous system, you'll memorize a lot of this stuff. And I can tell you from close personal knowledge, okay, that this is one of those things where unless you're going to go back and be a neurosurgeon or a neurologist, okay, you memorize it for the test and you memorize it for your boards, and that's the last time you ever have anything to do with it, unless you teach at FSCJ or some other place, okay? And there again, I don't know all these tracks. I did it one time, and I did for a test, okay? We have ordered neurons, okay? Don't have a 1, 2, 3, but this is how we can describe them, okay? This is how we can describe neurons in an ascending pathway. This pertains to an ascending pathway. A first order neuron, okay? Well, first order neuron is usually a sensory neuron. A second order neuron is usually a connecting in neuron. And the third order neuron is going to go up from someplace, okay, usually the thalamus, up to the cerebrum, okay? If you happen to get a matching question that says, what is the gateway to the cerebrum? And then one of the choices is thalamus. I think I might pick that one. See the advantages of coming to the lecture. If you happen to get a matching question that says, what is the gateway to the cerebrum? And thalamus is a choice, which it is, I might pick that one. Okay, first track we're going to look at is the spinothalamic tract. It's a non-specific tract, non-specific. Decussation occurs in the spinal column. That means it crosses over, okay? Well, that we figured it had to cross over somewhere because our general knowledge, not everything, there are some exceptions, there are 2 major exceptions, but our general knowledge is that the left half of the brain controls the right side of the body, and the right half of the brain controls the left side of the body. So if we're getting information, if we're going to get information from the left half of the body and it goes into the spinal cord, okay, goes into the spinal cord, into the central nervous system, how is it going to get to the opposite side? Well, it's going to have to cross over at some point. And rather than say cross over, they got this word called decussation, okay? And so the spinothalamic tract is concerned with pain, temperature, and coarse touch. It's non-localized. You can't be specific about it. So you know that you got some generalized pain, okay, in this area, okay? We're going to look at one that's got much more specificity. But you got some generalized pain in this area, and it's going to decussate, which means it's going to cross over. The first order neuron is a touch receptor, which synapses with the second order neuron in the spinal cord. Where is the cell body for the first order neuron, which is an afferent sensory neuron? It is in the dorsal root ganglion, which is inside the central nervous system. So the first order neuron is the neuron from the receptor into the spinal cord, okay? The second order neuron is in the spinal column, so it's an interneuron, and it's going to link the first order neuron, and it's going to take that link up to the thalamus, okay? It's going to take that link up to the thalamus. And then the third order neuron is going to take it from the thalamus to the cerebrum. So this is our first order neuron, our second order neuron, and a third order neuron. This only occurs in ascending pathways. And so if we looked here, this is our receptor here. This is our receptor here. And this is our first order neuron here coming in. Notice the cell body here. Notice the cell body. You know, it can come in at more than one place, okay? The cell body is in the dorsal root ganglion. Okay, it comes in here to the dorsal posterior gray horn, okay, and then it connects with a second order neuron. This second order neuron is going to go up. So if it comes in this level, it comes in this level, they're still going to go up, okay, and they're going to go up here to the thalamus. This is the thalamus. The thalamus surrounds the third ventricle. The thalamus surrounds the third ventricle. So if you look for the third ventricle, that's where the thalamus is. Thalamus is the gateway to the cerebrum. Okay, and then it's going to anastomose with it's going to interconnect. Okay, it's going to end on the dendrite of the third order neuron, which is going to go up into the cerebrum. So notice we started with this area being stimulated, okay, but we ended up on this side of the brain. We call that a crossing. We call that a decussation, okay? And do you have to know that pathway? No, okay? Most of the time I just skip over the slides, but this illustrates a good about what a decussation is and what is first, second, and third order neuron. Dorsal column, so this is our second, that was our first one, spinal thalamic. This is our second ascending pathway. And like I say, you don't have to memorize them. The face-to-face people did have to memorize them, and they would just have to memorize the writing part, okay? Dorsal column, medial lemniscal system, specific tracts, okay? This one goes, okay? This one does the same thing. It's going to decussate, okay? But notice in the spinal thalamic tract, it decussated, which just means crossing over. It decussated to the level it came in. This particular tract is going to decussate in the medulla. So our first order neuron is going to go from the receptor inside the spinal cord, okay, and it's going to decussate in the medulla. Straight through transmission of specific sensory receptors, straight through transmission of input from specific, not generalized. Last one's generalized, okay? Discriminating touch, pressure, and vibration. First order neuron is from the receptor to the medulla. But remember, for this first order neuron, if you were asked where is the cell body of the first order neuron in an ascending pathway, it's in the dorsal root ganglion, okay? It's in the dorsal root ganglion. Second order neuron starts at the level of the medulla, okay, and goes up to the thalamus. The medulla is where the decussation is going to take place. And then the third order neuron goes from the thalamus to the cerebrum. So the thalamus to cerebrum. So we're going to have our decussation at the level of the medulla. Or let's see if this is the... And here we go, the medulla oblongata. This is where so we've got our first order neuron coming in and going up this tract. This is the tract, okay? This is located in the posterior funiculus, okay? If it's on the other side of here, it'd be the lateral funiculus. Here's our first order neuron coming from the foot, coming from the hand. So it's going to be a long neuron, which is going to, and notice also, I keep emphasizing this because when you get to the fourth test, I guarantee you there's going to be a question, where is the cell body for the sensory afferent neurons? And they are in the dorsal root ganglion. Okay, so it's going to go up here to medulla, then it's going to decussate. That means it's going to cross over at the level of the medulla. Okay, now we have our second order neuron going to go up to, guess where? The thalamus. Okay, what's the gatekeeper of the cerebrum? What's the gateway to the cerebrum? If you've got a matching question, when the test is going to open up tomorrow, I would put that it is the thalamus. Okay, and it's going to go up to the cerebrum. I already told you a matching question. I pretty much told you a lot of, about half of your short answer questions, because the ones we talked about, especially the ones that are complex, like the how is the muscle depolarized and the action potential, that's going to take 4 or 5 paragraphs to write. So that's going to be a 10-point question. And so you're not going to have, you won't have that many questions. When I say it's 50% of the test, you get 3 10-point questions. That's already 30%. Last ascending pathway we're going to look at is the spinocerebellar pathway. Spinocerebellar pathway, dorsal and ventral. Does not decussate, or does it twice? Does not decussate, or does it twice? Well, why is that? What did we learn about the cerebellum that was different than the cerebrum? Okay, then was different than the cerebrum. In the cerebrum, we're talking about sensory motor. Left hemisphere controls right side of the body, right hemisphere controls left side of the body. In the cerebellum, we learned that right lobe of the cerebellum controls the right side of the body. Left lobe of the cerebellum controls the left lobe, left side of the body. So this is a right side, left side. So if it decussated for whatever reason, okay, in other words, if it crossed over, it would have to cross over twice, because that means it's going to have to come back, because it's on the same side. Okay, it's on the same side. So this is of the ascending tracks. This is one of the areas, okay, that is, if it decussates, it may decussate twice, because it's going to be on the same side. And I would remember that factoid, okay, one of the factoids we just talked about. There's another interesting area that we mentioned in the last lecture that is not, that is only on one side of the cerebrum. So, you could see a short answer question there. What 2 areas of the brain, sensory motor, usually the left side controls right side controls left side, but in 2 areas of the brain, it's not that way. We've already mentioned one, okay? And then there's a second one. But the cerebellum is the same side, okay? So you see, that's right out of your notes, that's right out of the slides, that's right out of my lecture. But if you're not familiar with your notes, because it's not going to be right next to each other. It's not going to be right next to each other. And so if you've got to spend 10, 15, 20 minutes looking at your notes, because number one, you never even bothered to fill them out. Or number 2, you never even looked at them since you filled them out, then you're going to have a lot of trouble answering the questions that I'm going to ask, okay? But that's a simple question, because you already know half of the answer there. Okay, and this is the ascending pathway for this, okay? So these are the ascending tracks. Descending tracks, we look at 2 descending tracks. Now we don't have the first, second, and third order neurons in the descending tracks, okay? We have upper motor neurons and lower motor neurons. Upper motor neurons and lower motor neurons. Direct pyramidal tract involves 2 neurons, okay? This is the pyramidal tract. The upper motor neuron originates in the precentral gyrus, okay? Precentral gyrus courses through the cerebral peduncles of the midbrain, okay? Then the pyramid tracts in the medulla, terminates in the spinal cord. So this is upper motor neuron. and then synapses with the lower motor neuron in the anterior gray horn. Okay, in the anterior gray horn. Well, that would sort of make sense. Okay, because remember I said we have two roots that are going to come out of the spinal column. They're going to make up the spinal nerve. The dorsal root is the sensory root, and the ventral root is the motor root. Okay, well, if we brought it back down through the dorsal area in the dorsal gray horn, or even the lateral gray horn, then we have to travel. Whereas if we bring it down through the anterior horn, okay, then we're already there. We're going to already go out. So sometimes I just look at the practical things. How we're going to, how is this going to be done? Controls distal extremities, fine motor skills, involved in involuntary control of the scale of, voluntary. I just read that sentence, okay, and then I said fine motor control, and then I looked at it and it said involuntary, but it actually said voluntary. So this is a track that is going to do fine motor control, and it's going to use the voluntary muscle. So it's going to use the voluntary section of the motor, the efferent roots that are coming out of the spinal cord. Okay, this is just a descending track. And then the other one is called the indirect. Okay, this one was called the direct pyramidal. Okay, this is the, and we had an upper motor neuron and a lower motor neuron. This is the indirect extrapyramidal. They made up of a bunch of tracks. Okay, I'm not going to ask you the bunch of tracks. I might say indirect and direct pyramidal and extrapyramidal. Okay, overlap with a pyramidal track. Upper motor neuron originates in the basal ganglia or the brainstem, as opposed to the pyramidal tract, it originated in the precentral gyrus. Concerned with muscular action, coordinated balance, and posture. Also head, neck, and eye movements, heavily dependent on reflex activity. Okay, and notice it's going down the anterior horn too. And this is one of the descending tracks. Okay, so that's all we're going to talk about. If you were in a face-to-face, you'd have 3 ascending tracks and 2 descending tracks. You wouldn't have to follow the pathways. You just need to know whether it decussates or not decussates. It's a moot issue since you're going to have open book, open notes. But if you haven't gone through it, haven't listened to the lectures, haven't listened to the slides, listen to me, then you might not pick up on that. Amylotropic lateral sclerosis is called Lou Gehrig's disease. This is what Stephen Hawking died from, except he had a variant, because most people are dead that have this within 5 years. Obviously, he got this as when he first started college, so it's late teen, early 20 years, and lived for it with it a long time. Okay. The immune system attacks the ventral horn motor neurons and the pyramidal tract. It has related to glutamine production. Patient can't walk, eventually can't speak, swallow, or breathe. And so, if you followed Stephen Hawking or went back and watched his videos, this was his progression. Okay. Eventually, how he first got evaluated was he started stumbling. Okay. He started stumbling. And then he had problems, other problems, got confined to a wheelchair because he couldn't walk, okay, and then lost his ability to speak. He put letters on his computer based on his eye movements, okay. That's how he did. He put letters on the computers, and so he was able to live a long time because he had good care. And you had, probably had the money to afford full-time nurses and things like that. But generally, this is a disease that is progressive in the last 5 years. And like I say, the reason he lived so long is because he had a variant of it. He didn't have this virulent progressive disease. He had a variant of it. He still had it. Spinal cord injury, some definitions: paralysis is loss of motor function. Paresthesia is sensory loss, which is tingling. Okay, you experience paresthesias. If you put your arm up on a bench. Okay, put your arm up on a bench, you can get paresthesias. Paraplegia, okay, is lower body paralysis. That's a transaction, and Intraction can be complete severance, or it can be a severe contusion of the cord between T1 and L1. Okay, that would result in a paraplegia. Okay, that's lower body paralysis. Okay, quadriplegia, all four of the limbs are paralyzed, transection of the cord in the cervical region above C5. Depending on how high up the cord gets transected. Okay, C3, 4, and 5 are what keep the diaphragm alive. So if you remember that little jingle, it actually got me a point on attending rounds in physical medicine and rehabilitation, because I remember that jingle, because that's one of the concerns of physical medicine and rehabilitation, because they see a lot of paraplegics and quadriplegics, is what innervates the diaphragm. So 3, 4, and 5 keep the diaphragm alive. If you have seen these quadriplegics, they do a lot of abdominal and abdominal breathing out. Okay, whatever the muscles they can recruit. Okay, to breathe, and if it's very high up, they have to go on a ventilator. Now, this is one of the areas that are being worked on with stem cells, okay, nervous system stem cells, and being placed in, and see if we can get spinal cord regeneration. I think there again, I don't read the literature and don't keep up with this stuff, but I think that there's some promising work there. And so some of you in this class could be somebody that's doing some of that work, doing some of that clinical work, okay, on a clinical basis. You may even be somebody doing basic research work. You might be like Dr. Fauci, who was a clinician and a researcher, okay, and did a lot of work on a lot of things, okay. So, and then hemiplegia is a loss of one side of the body. It's usually not spinal cord injury, but it's usually caused by brain injury, usually an embolus or a stroke, okay. And you'll see somebody with a stroke have lost the right, with a stroke on the left side, have lost the right side of the body. And we're just talking about the spinal cord receptors. Okay, generalized things about receptors. Most are specific for a specific stimulus. Okay, if you've got a pressure receptor, it's specific for a pressure. If you've got a chemical receptor, a lot of chemical receptors on your tongue, it's specific for a chemical. If you've got a light receptor, pain receptor, the receptors are fairly specific. Okay, fairly specific. Potential generator, grating call receptor potential, okay? Unlike the nerve itself, remember we talked about the nerve sits around about -70. Once it gets to -55, which is threshold, it's going to fire. It's going to go up to +20, +30, depending on where you read. And then it's going to come back, and it's going to go back down to about -80, hyperpolarization, because of potassium. Gates don't shut up right away, okay? So each of these receptors have a different threshold. Obviously you wouldn't want a light touch threshold receptor on your buttocks, okay? If you're sitting on your buttocks now, you wouldn't want light touch receptors there, because they would be firing off all the time, okay? Transduction is a change in the stimulus, okay, that's going to emit a signal. You can classify them. You remember anatomy and physiology people, they classify things by location, by stimulus type, by structural complexity. By location, stimulus type, structural complexity. Exterior receptors, information about conditions outside the body. So we have interior receptors and exterior receptors, because we have sensation. If I eat 10 crystals, if I decide to go for the, when I was a plastic surgery in Gainesville, plastic surgery fellow in Gainesville, you could get 10 crystals for $2.50 with the crystal right above the back entrance to the emergency, back up the entrance to the emergency room. So a lot of times when I came out of the emergency room, I wouldn't get 10, but I get a bunch of crystals. And so you will get some signals from inside your stomach, okay? Unless you're a professional eater, or if it gets cold or gets hot, okay? Or if you have suffered pain, okay? You're going to get all these receptors, and these are conditions outside of your body. Most of the cranial nerves are like that. Not all of them, most of the cranial nerves are like. You get interior receptors located by visceral organs, blood vessels, chemical change, stretch, and temperature. We have receptors in our joints. We have receptors in our muscles. Is our muscle being stretched too much? Proprioceptors involve information about movement found in the muscle and connective tissue, monitor stretching. Okay, proprioceptors provide information about movement. They're found in the muscles and connective tissue, monitor stretching. Chemoreceptors, taste and smell. Mechanical receptors, touch, press, stretch. Auditory balance. Photoreceptors, light. Okay. Thermoreceptors, change in radiant energy. Nociceptor, I can't say that. Tissue damage, okay? If tissue damage occurs, these receptors are fired off. We can have them structural, okay? They can be non-encapsulated. In other words, it can be a naked nerve ending, okay? A naked nerve ending. If you get a superficial burn, okay, those are the ones that fire off and are painful, okay? Those naked nerve endings fire off and are painful. These are the different types. You can have free nerve endings. You can have modified free nerve endings, which are Merkel's disc, and you can have hair follicle receptors. And those are the three basic types of free nerve endings. Merkel's are disc. Okay, free nerve endings are just free nerve endings, all types. Merkel's are tactile disc. They are modified. They're modified, okay, but they're still free nerve endings. And obviously we have hair follicle receptors that monitor any touch to the hair. We can have encapsulated, which are surrounded by connective tissue. As you can imagine, we have some types of that. We have the tactile Meissner corpuscles. This tells you what they do. We have the Pacinian corpuscles, okay? The deep pressure, so these are the ones that are firing off. If you just think about it, okay, now I can feel my butt, whereas normally feel your buttocks. Excuse me, didn't mean to say butt. I feel your buttocks, okay? And once you concentrate, you can feel it. And then the Ruffinian corpuscles, they deep pressure stretch and slowly non-adapting. So this is the non-adapting ones. These made rapidly adapting. So the problem with paraplegics and quadriplegics, they no longer have these nerve endings. Well, they may have the nerve endings, but they're no longer functional. So most of the time they atrophy. And so they don't know to move around, okay? They don't know to move around. And the number one thing that paraplegics get, if you don't give them good discharge instructions about moving, you and I normally just move, certainly every 5 minutes, maybe more often than that. We may shift side to side in your chair. Excuse me. But we move a lot, okay? They don't do that. They don't have the same sensation. So if you watch somebody that's really good and really trained, who's a paraplegic, they will lift up on the handles and they will move. They may have a buzzer in their thing, or they may have a buzzer in their head, because it's been ingrained to them to move. And that's why nursing home patients, especially if not paraplegic or quadriplegic, but somebody who just lays in the bed, if they're not turned side to side on a fairly frequent basis, they'll get pressure ulcers too. And those are very difficult. And all these folks to take care of, it's long hospitalizations. And then finally, you have muscle spindles. You have different kinds of receptors. You have muscle spindle. You have joint kinetic receptors and tendon organs. These are just monitoring what's going on in the receptors. And you can look at that stretch. Receptors are something that we go over. It's not a big ticket item with me. A receptor becomes less responsive with time and exposure, fires less frequently. Inhibitor produced, which blocks spinal transmission of the impulse. So you may work in some place that's really hot and you don't notice it's hot, okay? Or you may work in the operating room. Despite what it shows on every TV show that you've ever seen, operating rooms are very noisy places, especially if you've got a lot of machines going. If you go into an orthopedic surgeon's room, they got saws, they got drills, they got everything going. You go into a plastic surgery room. If you're doing liposuction, you got the liposuction machine going. You know, there's different things. And so, and certainly you have the ventilator going unless the patient's being bagged by hand, and that had to be a very short case. And so operating rooms are not as quiet as you think they are. Okay. But you get used to that noise. I mean, you know, every patient you go operating on, if it's going to be a big procedure, they're going to put an endotracheal tube and they're going to put them on a ventilator. Well, you don't even notice that unless something does inadvertent happens. Okay, unless all of a sudden you don't hear the ventilator going. By that time, way before that time, the anesthesia person would have recognized the problem and taken care of that. But that's what I'm saying. We adapt to things. Okay. Because they're around us. And so if you work in the hot place, I come into that place and I say, I can't work here. It's just too hot. And you say, what are you talking about? Okay. Or if it's cold, okay. I could not stock the freezer section of Publix. Okay. I mean, I just can't stand being cold. I couldn't do that. But I certainly could stock the produce section, which is my favorite part of Publix, is the produce section. Peripheral nervous system. We will talk about the autonomic nervous system next time. Peripheral nervous system, efferent pathway consists of a sensory afferent pathway, and we have a motor division. So we have peripheral nervous system as a sensory input to it, and we have an output. Okay, motor system. Part of that motor system is the somatic, the voluntary system, and the autonomic nervous system. This is what autonomic nervous system is what we spend our time on next time. Autonomic nervous system is very easy, and I'll explain it to you as we go. It's just what do you need when the T-Rex is chasing you? That is the bottom line. What do you need when the T-Rex is chasing you? Directional flow of information obviously comes in from the sensory receptor as an interneuron. Okay, interneuron may go upwards. We saw where some interneurons went upwards to the thalamus. Okay, that was a second order neuron, then from thalamus to cerebrum. If it's a reflex, a simple reflex arc like the patellar reflex, you'll have a sensory neuron coming in, an interneuron, and a motor neuron coming right back out. Peripheral nerve, first neuron chain, afferent sensory. There's the cell body. Where's the cell body located? In the sensory neuron. It is in the dorsal root ganglion. Spinal cord takes messages to the brain, second synapse. So we could have the interneuron taking the message to the brain. Then the brain would send down a fiber based on what it wanted to do. It might not want to do anything. Okay. But if it wanted to do something, it would send down a fiber and it would send it down in the ventral horn, okay, the ventral horn. Notice how if we have an interneuron on a simple reflex, it crosses the gray matter up to the ventral horn, okay? Then we have an efferent motor neuron, which is the response to the stimulus. It's the third order neuron. Effector organ causes a change in a muscle or an organ. Remember, that's why we talk about the motor side having either voluntary muscles or having in the autonomic nervous system primarily effects on organs, okay, and the organ systems. Peripheral nervous system, cranial nerves, okay. This is what I'm talking about. If you don't have this yet, you should get this, okay. It is the last thing in the module, okay. I put this together, all right. I put this together. These are the cranial nerves. This is the detail I expect you to know. Cranial nerve number one. Notice cranial nerves are not written in Arabic numerals, okay? If you write a cranial nerve in an Arabic numeral, you didn't bother to study cranial nerves. Cranial nerves are written in Roman numerals. If you cannot write 1 to 12 in Roman numerals at this point in your life, then this is something, obviously, you don't have to do it right now, but if you're going into the medical field, you may have to either be able to recognize them, okay? Now, you don't have to write 2020 in Roman numerals, okay? But you need to be able to write the Roman numeral for cranial nerve number 7 and cranial nerve number 9. So if you answer a question on the last exam, exam 4, or on the lab practical, and you write down cranial nerve and you put an Arabic numeral, which is the regular numbers that we write in, okay? Your question's wrong. It's as simple as that. It's wrong. So I'm telling you right here, right now, you need to write the cranial nerves and Roman numerals. Number 1 is olfactory, smell. It is sensory, okay? Does it have a parasympathetic component? 4 of the cranial nerves have a parasympathetic component. 4 of the cranial nerves have a parasympathetic component. I have the parasympathetic components here for the 4 cranial nerves, okay? This was a study sheet I used to give to the face-to-face students because this was usually an extra credit question on the lab practical. So, second cranial nerve is optic, vision, sensory. Third is oculomotor. We have 3 cranial nerves associated with moving the eye. There are 6 muscles to the eye. We have 3 of the 12 cranial nerves, 25% associated with moving the eye. This is oculomotor, eye movement, and also the upper eyelid. It is motor. Number 4 is trochlear, okay? Number 4 associated with eye movement, okay? It does the superior oblique muscle. I'm not interested that you know that, but it is motor. 5th cranial nerve, oculomotor has a, number 3 has a parasympathetic component associated with the pupil. I left that blank so that you could look that up, okay? Trigeminal is sensation to the face and chewing, okay? Everybody seems to think it's the facial nerve that's sensation to the face, but it's actually the trigeminal nerve that's sensation to the face. It is both, okay? Well, how are you going to remember that? Is it sensory, motor, or both? Well, you don't have to remember it, but on face-to-face meetings, you did. Was this cranial nerve, was it motor, was it sensory, or was it both, okay? And I have some mnemonics down at the bottom. Sensation of the face. Number's cranial nerve number 6, which is the last cranial nerve associated with the eye, all right? And it is motor. Facial nerve, okay? Facial expression and taste, both. And it also, this is the parasympathetic component, lacrimal gland, submaxillary, submandibular gland, mucous glands. So if we don't need a lot of mouth, a lot of digestive enzymes, we don't need tears, although if a T-Rex was chasing me, I'd be crying, okay? But we don't need a lot of these glands around our mouth secreting during the parasympathetic, excuse me, they do secrete during parasympathetic. That's the point of this. They are secreting during parasympathetic because that's when, after the T-Rex has been caught or we've outrun the T-Rex. So this is the parasympathetic. That means that these are now secreting, okay? So the lacrimal gland is secreting, submaxillary, submandibular mucous glands. So the facial expression and taste are the cranial nerve number 7, and it has branches like fingers going out. Okay, it has branches like fingers going out. And so that's motor. When you do a parotidectomy, the facial nerve goes right through the friggin' middle of the parotid gland. Okay, it goes right through the middle of the parotid gland. And so you have to have a nerve stimulator because the parotid gland is just glandular tissue, a lot of connective tissue in there. You're trying to get the parotid out, but you're also trying, obviously, to preserve the facial nerves, the branches of facial nerves. And so you do your dissection, you find your facial nerve branches, you get the parotid gland out. The first thing you do, as soon as the patient wakes up in the recovery room, you test all the branches of the facial nerve because they are now awake. Because what's going to happen, just like every other thing where there's injury, and remember, surgery is a control injury, but still an injury. You're going to have swelling in that area. So you all of a sudden may not be able to move part of your face because of the swelling. But you want to make sure that you have documented in the chart that when you saw the patient right after surgery in the recovery room, when they were awake, you documented the facial movements on that side. That's just a thing. Vestibulocochlear, this is cranial nerve number 8. We will look at that when we do the special sensations. It's hearing and balance. We'll spend quite a bit of time on the ear. That'll be one of your diagrams or 1 or 2 of your diagrams for the lab practical part, okay? When I was doing in medical school, it was called acoustic, okay? And so they now call it vestibular cochlear and don't call it acoustic anymore. Cranial nerve number 9 is glossopharyngeal, okay? Oral sensation, taste, salivation, swallowing. It's both, and the parasympathetic component is salivation. Vagus nerve, the vagus nerve, 11 of the cranial nerves stay in the head and neck area. One cranial nerve innervates essentially the entire abdomen, okay? Essentially the entire abdomen and its contents. And some of the thoracic contents. That's cranial nerve number 10. That's the vagus nerve. Sensation to throat, heart, abdominal organs, movements of throat, soft palate, okay? The vagus nerve is the parasympathetic component that slows down the heart, okay? Smooth muscle airways, lungs, and GI tract. Then the accessory, cranial nerve number 11. When I was in medical school, we call this the spinal accessory. Shoulder elevation and head turning, motor, and hypoglossal. Tongue movement, motor. This is I would make sure I printed it out. I would keep it, okay? Because you're going to need to go back to this in other classes, okay? Or studying for your boards or something. And this is something that I personally put together. And gave it to my students. Now for mnemonics. You can get a mnemonic for almost anything. When I was in medical school, we went to the bookstore and we bought the Red Book of Medical Mnemonics, okay, for anatomy and physiology. Now, all you have to do is just look it up. And they are clean ones and they are dirty ones, okay? This dirty ones obviously use inappropriate language. But just you want to get a mnemonic for anything that you want to, okay? You can. And like the mnemonic for the groin is navel, okay? Going from lateral to medial, it's nerve, artery, vein, empty lymphatics, okay? That means the artery is going to be lateral to the vein. And so if you're trying to do a femoral venous puncture, you put your fingers on the artery and you put your needle in medial to where you feel the pulse, and you should go into the femoral vein, okay? Underneath the rib is vein, artery, nerve. So if you're going to do a rib block, you should do the injection right underneath the rib because that's where the nerve is. This was the one I learned some 40, going on 50 years ago on Old Olympus Towering Tops, the Finn and German views some hops. That was the one I learned almost 50 years ago. And I still remember it to this day. The only problem is, on Old Olympus Towering Tops, a Finn, and remember I told you that we called the vestibulocochlear nerve, we call it the acoustic nerve, okay? And we called cranial nerve number 11, which is now called the accessory, we called it spinal accessory, okay? And now, and we call it and now they call it accessory, so this one is not as pertinent, okay? Here are some that I picked up. This one, odor of orangutan terrified Tarzan after 40 voracious gorillas vicariously attacked him, okay? I try to remember that. That's very hard. They actually had a contest back in the day, and you could, if you were in any of the professional schools, it didn't matter what you were in, you could submit an entry. And Duke University, I think it was the medical school, okay? And I think this was what they submitted, and they won, okay? And I forget who was doing the contest, okay? This is another one I found on occasion. Our trusty truck acts funny, very good vehicle anyhow, okay? I could not remember either of those other two if I need, well, I could if I needed to, because that would be the ones I would learn. I learned this other one and used to say it. And now if you ask me what's cranial nerve number 10, I know it's vagus because viewed, okay? I know it's vagus because I remember my cranial nerve names, okay? And all I need is a mnemonic to put them in order, okay? Now about sensory, motor, or both, okay? Here's for your sensory, motor, or both. This is the one I learned 40/50 years ago. Some say marry money, but my brother says big brains matter more, okay? S obviously is sensory, M is motor, and B is both, okay? So number 10 is both. Look at that. Number 10 is brains. Number 11 is motor. Number 11 is motor. So learn this one, not for the test. Obviously, you got these here. Okay. You got these here. But when you're sitting there for your boards and you need that one extra question to pass your boards, to get your nursing license, okay, or to get your practicing license for whatever healthcare field you're going to go in, and you need one question. And if you have learned these two mnemonics, you may be able to pull that question out of the hat, okay? And that's all you need, the one question. Because all you got to do is pass. Nobody cares what you pass with. You just have to pass, okay? Nobody cares if you've had the top score. You just have to pass so that you can be able to practice whatever your profession is. That's why I keep emphasizing about the posterior pituitary. It secretes two hormones, which is oxytocin and an antidiuretic hormone, if I haven't got to that. But this you ought to print, you ought to put it away somewhere and have it, okay? Because what happens is obviously once we're done with the class, you're not going to have access to these things anymore, okay? And so I would print that out because that's something I did. And I usually hand it out. Cranial nerves, 12 pairs of nerves that arise on the other side of the brain. First two pair emanate from the forebrain. That is the olfactory and optic. Remaining 10 nerves come from the brain stem. 11 nerves serve head and neck structure. Vagus nerve serves the viscera. I guarantee you it's going to be a question. Guarantee you with 100% when you get to exam 4, that's going to be a question. All right. So 12 pairs of cranial nerves. This is their thing. Okay. Parasympathetic, yes or no. Okay. Sensory function, motor function, cranial nerves doesn't really tell what it does. Okay. So I took parts of this, parts of other things, and put that chart together for you. Like I say, print it out. When you're to exam 4, you just have it sitting with you in your notes. I would print it out. I'd put it with my notes and I'd save my notes. Okay? Because this is what Dr. Oler thinks is the important things that you need to learn for Anatomy and Physiology 1 and 2. And if you take my 2 class, we'll have the same thing. We'll have these same type of notes, okay? Some are predominantly motor, some are sensory, some are both. Well, we now know that some say marry money, but my brother says big brains matter more. And we know which ones are sensory and motor. We can just write that down and we can put a number up above it and we can tell if number 10 or number 11 or number 12 is sensory, motor, or both, okay? We may not remember exactly what it does, but that might not be the question, okay? Is it sensory, is it motor, is it both? Okay, we're not going to go, you can go through these with your little thing, with your chart, that little thing. You'll probably see this diagram, essentially from this part forward, going backward, that'd be that would be literally 2 diagrams on your lab practical. That's what I mean when I talk about the central nervous system / sensation practical, or nervous system / nervous system lab practical. It'd be diagrams like this and asking what these parts are, okay? And so these are the nerves here, and you can go through that and read all the stuff, but I've given you the gist of what you need to know, okay? Spinal nerves, numbered according to the region of the spinal cord which they exit, okay? Remember that there are 8 cervical nerves, but only 7 cervical vertebra. So the first cervical nerve comes out on top of C1, and the second cervical nerve comes out at the bottom of C1, okay? Numbered according to the region of the spinal cord from which they exit. We have cervical nerves, thoracic nerves, lumbar nerves, sacral nerves, and coccygeal nerves. 8 cervical, 12 thoracic, okay? Connected by 2 roots in the spinal cord. We've looked at this picture, okay? They are 2 roots. There's a dorsal root and a ventral root. Dorsal root is sensory afferent. So this is where your sensory fibers are coming. Remember, they're coming in the spinal nerve, okay? They're coming in the spinal nerve. They're coming in as sensory fibers, and they're going to go in the dorsal root. Ventral root, motor efferent fibers. Remember, when we say motor, that includes both voluntary muscle and the autonomic nervous system. Dorsal root ganglia, okay. I have emphasized that to you about 1,000,000 times, dorsal root ganglion. Okay. That is where the cell body is for the sensory neuron, the first order neuron. That is where the cell body is, in that dorsal root ganglion. Whatever level it comes in, that's where the cell body is. Dorsal and ventral roots join before exiting through the intervertebral foramen. So all spinal nerves are mixed. Guaranteed. I'll give that as a true-false question. Please read the true-false questions. Don't just stick it in your browser in Google and say, oh, it's got the same with a few words, and I'll put that as a true. I guarantee you, because of the however many true-false questions, I usually change a word or two in there, okay? I usually change a word or two in there. I know which ones I did. And I can guarantee you, I can tell you who Googled them, okay? Because they will get every one of them right except for that one, except for those two, except for that three. Because they'll Google, they'll see a couple of words, they'll look in the thing, it says true, they'll put true, and they'll go on. And go ahead, keep doing that. Because I know who you are. It's easy to spot you, okay? If there's 10 true-false questions, 4 of them are going to have a word changed. Okay, so just read the question, come up with an answer, put down true, false. Okay, but there again, if you copy directly from the internet or paraphrase, that means you took exactly what it said on the internet and paraphrased it because you took some of the adjectives out and changed the last word of the discussion, and that would like fool me. Okay. Because all I do is if your answer looks suspicious, I copy your answer, I paste it up on Google, and it takes me, because Google will take you to the first source, which will be the one with the most words that you put up there. And so it doesn't matter if you went to the 3rd page of the search engine, because Google will take me to the page where you copied that and paraphrased it from, and you'll get a 0. Okay. And you don't want to do that on a 10-point extra credit question. Okay. You don't want to do that. Remember, I give partial credit. So make sure you put pencil. Well, can't put pencil on the thing, but make sure you do. So dorsal root joins exit mixed nerves. Spinal nerves are mixed. After exit, branching occurs. Okay. We're going to have a dorsal rami, which is going to innervate the posterior trunk. They're mixed nerves. Okay. Motor and sensory. So once it comes out, it's not going to branch back into those same roots, okay? It's going to come out and it's going to branch as a mixed nerve, okay? It's going to have motor and sensory fibers. The dorsal ramus is going to go to the posterior trunk, and the ventral ramus is going to go to the anterior trunk and the limbs, and it is a mixed nerve. Ventral rami branches, innervates anterior trunk muscles in the skin. Ventral rami from T2 to T12 innervates specific regions of the body, and we'll look at that. It's called dermatomes. Okay, it's called dermatomes, and that is it gives you a good idea of if you're putting a block in, like a spinal block, okay, and using spinal anesthesia, what level the anesthesia is risen to. It also will give you a general idea if somebody is a paraplegic, what level of transection there is a spinal cord. Obviously, you're going to get more information when you do CT scan, MRI, but that will give you an idea, okay? Ventral nerves, not T through 12, don't go directly to body structures. They form networks on each side of the body, which form plexuses. There's 4 plexuses. You need to know what they are. You don't need to know any of the specific nerves, okay? Can be divided into 4 plexus regions. The cervical plexus, so here's what happens. All these nerves coalesce here, okay? And then they're going to come back out as these named nerves, okay? So this is the cervical plexus, found deep in the neck, C1 to C4, serves muscles, the head and neck, okay? May serve, the diaphragm connects with some of the cranial nerves. The brachial plexus, okay? This is part of plastic surgery is hand surgery, okay? Hand surgery is the extremity surgery. So I learned this in detail, okay? This is the brachial plexus. I learned this thing in detail. Okay. It is very complicated, very complicated. Okay. So if you want to know how much detail you learn, I never learned this in general surgery. Okay. I was a general surgery resident for 5 years, plastic surgery fellow for 2.5 years. But when you get to whatever your subspecialty or whatever your specialty is going to be, then you're going to learn stuff in detail because nobody can know everything about medicine. Nobody can know everything about medicine. So this is one of the things that I learned in detail. We had once a year, we had conferences, and this would always be a conference, the brachial plexus. How do we diagnose brachial plexus injuries? How do we repair brachial plexus injuries? Where can we get, because usually if somebody had a brachial plexus injury, they had a gunshot to the axilla or a knife wound to the axilla, okay? They had a gunshot wound or a knife wound to the axilla. So you're not going in there in fresh tissue, okay? You're going in there where tissue's already damaged. And in really hard cases, it's not uncommon to get the textbook or bring the textbook with you and have anesthesia have the textbook open, because sometimes it's really, really hard to pick out these things, okay? So I'm just giving you some day-to-day practical things. If you ever go into the OR and somebody's got a textbook open, that think about, they may be operating on this, okay? And they may be just a little bit confused, even though they know it like the back of their head, okay? And so this is what you had to learn in the brachial plexus. What nerves went to what trunks, went to what divisions, went to what cords, went to what nerves, okay? And where those nerves innervated and what they did. So you want to learn what you have to learn in your residency, or what you have to learn when you get to whatever you're going to be, okay? So if you were going to be a nurse, okay, you wouldn't have to learn this, okay? If you were going to be, maybe if you were going to be on a physical medicine rehabilitation, you might, okay? You might. It just depends on what depth of knowledge you need, okay? You can amaze a lot of people if you learn it just for the heck of it, okay? But this is a bugaboo for me for 2.5 years. Lumbar plexus, same type of thing. Multiple nerves, multiple spinal nerves coalesce and then reform other nerves. Lower extremity, mostly anterior external genitalia, and then the sacral coccygeal, found on posterior wall, serves buttocks, perineum, and rest of lower extremity. When we talk about the caudal block, okay, we're talking about blocking this area in the perineum, because that's where you may have to do, that's where you might have to do an episiotomy or something. Dermatomes, this is what I was talking about, those T2 through T12, but there's also dermatomes all over, but these have generalized, don't say specific, they have generalized areas that they innervate, and you can get a generalized area. Somebody's a paraplegic by how far up they still have sensation and where they lose sensation, okay? Also, if you're doing spinal anesthesia and they're doing a hernia repair, obviously you need to have this area and this general area anesthetized, but you certainly don't want it up here, okay? You certainly don't want it up here because you don't want to interfere with any of the respiratory things, okay? So not 100% accurate, can help to determine injury of spinal injury or spinal nerve injury. I could never remember how many times I go out and in. Referred pain, the body is not really good. Some places it is, some places it's not. Heart's perfect example. For a heart attack or problems with your heart, you can get pain up in your neck. You can get pain down your left arm. Okay. For stomach, for liver pain, you get pain in a different area. You can get diaphragm pain up in the head and neck area. Appendicitis pain, especially appendicitis, that's the one we dealt with most. But most of the intra-abdominal pain, until it localizes, is periumbilical. Okay, it's generalized, it's periumbilical area. So most people that have appendicitis will tell you, hey, I just started having some, I had a little bit of fever, I was throwing up, I had some diarrhea, and I had this pain around my belly button. Okay, a couple hours later, it went down towards into my groin. Okay. And so once whatever's inflamed, and at that time, that would be the appendix. once it's inflamed and butting up against the peritoneum, and it also has its own nerve supply, then you're going to get some more localized pain down into the right lower quadrant. And if you press down in McBurney's point, which is 2/3 the distance between the umbilicus and the anterior sphenoid spine, which is your hip bone, and you release real quick and they jump off the stretcher, that's called the chandelier sign, and that's pathognomonic in a male of appendicitis, and in the female, it's probably pathognomonic of appendicitis, but they also have ovaries and other structures in that area that you have to worry about. And so there is referred pain, there is, and it's not, some of it's not very specific. Spinal reflex act, predictable autonomic response to change, okay? We have a receptor that detects, so think about the patellar reflex. We got a receptor, and that tendon is going to detect a stimulus, okay? Detect some kind of change. Right here, the dorsal root ganglion is where that cell body lives, okay? Sensory neuron enters the dorsal root ganglion with cell body in the dorsal root ganglion. Integration directly with motor neuron or interneuron. So it can integrate directly with the motor neuron if it's a very simple reflex, okay? Or it goes with an interneuron. An interneuron may send it up to the cerebellum to make a decision. Exits the ventral root, okay, with a cell body in the ventral gray horn, okay? It goes to the effector gland or the effector muscle, okay? If it was in the leg, okay, it's going to extend the knee, okay? Extend the knee. Because due to the patellar reflex, you've got the knee flex, it's going to extend the knee. Ipsilateral means on the same side, okay? This is an example of a sensory neuron and a motor neuron, and no interneuron. So we've only got 2 neurons here. Notice, okay, now we talk about the neuron, the motor signal going out to only one particular muscle group, okay, one particular muscle group to extend the knee. But we also have to relax the other muscle group. Okay, we also have to have mother, you know, we have an agonist and an antagonist. We have an agonist and an antagonist and a synergist. So if I saw those on a matching question, I'd want to know what they were. An agonist, an antagonist, and a synergist. So we've actually got 2 things going out here, one to the agonist muscle and one to the antagonist muscle. So that's why you actually see 2 neurons going out here, okay, out in the ventral root, which is the motor root, which goes into the spinal nerve, which goes to the spinal nerve, which is a mixed nerve, and it's going to go to this muscle, okay? Patellar reflex, striatal and patella receptors transmitted neuron towards cell body, dorsal root ganglion, axon entered the dorsal root, sensory synapses directly with the dendrite of the motor neuron in the spinal cord, passes through cell body of motor neuron, down axon, carries impulses ventral root, reaches the effector thigh muscles, leg extends his knee as quads femoral muscles contract, and then we have the hamstring muscles relax. So this is just a simple reflex. Same type of thing, we have reflexes that if biceps reflex, if we start tilt, if we lose control of our brachioradialis for whatever reason, we automatically contract the biceps. We can have a polysynaptic reflex where if one side, say we tap the biceps tendon, okay, biceps tendon, you can get the biceps tendon, biceps muscle, go down to distally, okay, distal to the biceps muscle, you can feel the biceps tendon, where we have one muscle is going to contract and one muscle is going to extend, and it's going to go across, okay? So what happens is if we well, this is what they're doing. They're actually holding the arm down and getting against resistance. And on the opposite side, you actually extend the arm. This is a polysynaptic reflex. And so there's multiple connections here, and it's probably some kind of balancing thing, okay? Or if this was if this was somebody that grabbed your arm and had enough strength to pull you down, this is in preparation for a fall to position your cushion yourself with your outstretched arm. And so this is a polysynaptic reflex. I want to ask you about this, but they do exist, and this is where somebody's pulling down this arm, and you're actually, and this is a reflex, and you can demonstrate this. And if we were in the lab, we didn't try to demonstrate this on one another, but it's hard if they know it's coming. Okay. But if they don't know it's coming, then they'll extend the hand. Okay. Extend the arm on the other side. We have cutaneous reflexes. The most important one that you'll do is the Babinski, where you take a tongue depressor or a key or something like that, and you go along the lateral line of the toes, and they should curl inwards. Okay. If they're curling outwards, especially in somebody with a central nervous system injury, that's a bad sign. Okay. Or if they have no Babinski, that's even a worse sign. Each memory is so we're talking about memories now. Each memory is a sympathetic pathway or memory trace. Synaptic plasticity, pathway can change over time. We can add synapses to the pathway, subtract synapses from the pathway, or monitor them to make transmission earlier, easier, or harder. The way I think about this is as you progress through your medical career, and you learn more about particular things, you'll never use all the anatomy you use in anatomy and physiology 1 and anatomy and physiology 2. You'll use a lot of it, but you'll never use all of it. But the part that you use, you have scaffolding there. Okay, you have scaffolding there, and so you already have a structure built there. You may have forgotten about the scaffolding, but you'll be able to reassemble that scaffolding faster because you had initially had scaffolding there for say, if we're talking about the brachial plexus, you learned the brachial plexus and then you had to use it again. Say I was a plastic surgery fellow. I learned it ad infinitum as a plastic surgery fellow. Then I went out in the general plastic surgery practice, and I decided I really wanted to be a hand surgeon. Okay, so I decided to go back and do a year hand fellowship, and obviously a brachial plexus injury. You're now in the hand service, which is a combination of the general surgeons, orthopedic surgeons, and plastic surgeons. And so now you're going to learn it in great detail. Well, you've already laid that scaffolding. So that's where I think that's the modifying to make it a whole lot different. Short-term memory, seconds to hours, and limited to a limited amount of information. Working memory, limited capacity, 7 to 10 bytes of information. Okay. This, I'm sure you've done it, but I learned a lot of stuff in short-term memory. Okay. I was like most of you, I put off stuff to the last minute, and I crammed the last 2 days for a big exam. Okay. And I put all that in short-term memory, and it went away. Long-term lifetime can store large amounts of information. Think about everything that you've learned so far in life. Okay. And then multiply that by not multiply it, but think about, I'm 70 years old now. I have a huge store of information that I have learned, huge store of information about a whole number of things. And I'm still learning. As I told you, I listen to YouTube videos every night, whatever subject strikes my fancy. Now, a lot of times I go to sleep in the middle of them, but I still listen to them till I go to sleep. And you have the ability to learn a huge amount of information. Best way to do it is obviously go over your notes right after the lecture. Nobody does that. Okay. Go over your notes the next day, 4 days later, a week later, 2 weeks later, a month later. If any of you decide to go to law school, in law school, you have one exam. You have a final exam for the whole semester. That's it. You have no exams, no labs, no nothing. Okay. And it is a grind. And that's the end of the slides. Things I talked about to start with. Your exam should come out tomorrow. I'm working on yours first and the anatomy and physiology too. About half of it's going to be multiple choice, matching, and true false, probably 10 true false, 10 matching.